What I'm planning on actually speaking today about is about all the advances that have been made in the genomics that are actually allowing us to better diagnose as well as prognose and even for that matter predict therapeutic choices in Waldenström's macroglobulinemia. One of the key discoveries in this disease because of whole genome sequencing was the recognition that there are two highly recurrent mutations. One being in the MYD88 gene, which can be found in about 95% of all patients with Waldenström's macroglobulinemia, and a second mutation in the CXCR4 gene, which can be found in about 40% of all Waldenström's patients. Both of these are very critical discoveries because they allow us to better diagnose as well as prognose and predict therapeutic options for the disease. The MYD88 gene in particular allows us to discriminate Waldenström's against other diseases which often mimic because of similar features, including the secretion of IgM. And this is really important because there are a number of other overlapping entities that can look like Waldenström's but are treated very, very differently. Case in point is IgM multiple myeloma. Many times this can be confused with Waldenström's, but having the MYD88 gene allows us to be able to discriminate Waldenström's against this other entity. The MYD88 mutation also allows us to prognose. Those patients that have the MYD88 mutation actually do better from a survival standpoint versus those that don't. And today what we'll be talking about also is the mutations that have now been discovered in those patients that don't have the MYD88 mutation, meaning MYD88 wild-type disease. And this is really critical because these patients tend to have poor survival and they're also at higher risk of their disease transforming to more aggressive types of lymphoma. The underlying mutational landscape for these diseases actually shows us that they have gene abnormalities that are very similar to those that we find sometimes in aggressive lymphomas. And so this gives us now an understanding of why perhaps this particular small subset of Waldenström's patients are at higher risk of becoming transformed and higher risk of dying. It also perhaps will open up doors to alternative ways of treating these individuals. Now the CXCR4 mutation is also very exciting because CXCR4 is an important gene that allows for trafficking of Waldenström cells to the bone marrow. So if you have the mutation, cells want to go to the bone marrow and stay in the bone marrow, and there they receive actually microenvironmental support that allows them to grow and thrive and also be resistant against many drugs. And so ibrutinib is a very important drug because the MYD88 mutation turns on Bruton's tyrosine kinase and also turns on hematopoietic cell kinase. Both of these are targets of ibrutinib. So luckily, because of these discoveries, we now have a new drug, ibrutinib, that is highly effective. But that small population of patients that don't have the MYD88 mutation don't benefit, and those patients that have the CXCR4 mutations tend to show slower responses as well as less deeper responses and even more rapid progression of disease. So here we have now a mutation that will allow us to better understand when ibrutinib is appropriate and also what the expectation is with CXCR4 mutations as to the lag time with response and also understanding perhaps why these patients tend to have a different progression-free survival. All in all, we should be really excited because when you look at progression-free survival with ibrutinib, even in relapsed refractory patients, it's long. In fact, now with our 5-year data, more than half the patients still remain progression-free, particularly those that have no CXCR4 mutations versus those that don't. But even those that do, still their median time to progression was about 42 months. And I think for a heavily treated population, that's worth getting excited. Now, can we do better because of these discoveries? Absolutely. There are actually therapies that target CXCR4. One of the new trials that we're currently working on is combining the CXCR4 antagonist ulocuplamab along with ibrutinib in patients that carry the CXCR4 mutation. So these are two good examples where you can take two mutations that are actionable and actually deliver on therapy.